Good afternoon, and welcome to the Joseph and Evelyn Lowery Institute Real Talk Symposium. Today, we're very excited. I'm so excited to be with you today. My name is Blake Osborne. I am the Director of Programming at the Joseph and Evelyn Lowery Institute for Justice and Human Rights. And today, on what would have been her birthday, I won't say which year because I'll get in trouble even now. We're here to honor the legacy of Evelyn Gibson Lowery, who was a pioneer in the Atlanta area talking about the issue of HIV/AIDS, particularly in the Black community. And before I begin, I want to show a short video about Ms. Lowery and her work, and then we will get right to our program.
February 7th is National Black HIV and AIDS Awareness Day. A fun day where we can hang out with the students, get them to ask experts and people who know and work in HIV and AIDS prevention work every day, to not only give them information about HIV and AIDS, but to give them information about their resources.
And did you hear what she said about being undetectable?
The highest demographic group among both men and women are the African American population. Ages 13 to 24, the youth, is actually where the highest incidence rates of HIV and AIDS occur. Atlanta is one of the top 5 cities marked in prevalence of HIV and AIDS. Please get tested.
Thank you for that. And I apologize for the technical difficulties. The video is available on the Lowery Institute website for you to watch. But basically in 1989, Ms. Evelyn Lowery held an AIDS Awareness Sunday, which was an ecumenical service in New York as part of her commitment and her personal drive to dealing with HIV/AIDS in the Black community. And on this day, it couldn't be more apropos to launch our Real Talk series, which is a Lowery Institute Scholar Activist program in which our scholar activists, our change agents, use their voice to talk about issues that are near and dear to our community, issues that are important, issues that are critical, and talk about them directly from their own perspectives in their own lives. For us, Real Talk means all holds bared. So the conversation we're going to have today and the conversations we will have in the future, we will pull no punches. We will talk directly to the issue and try to engage in conversation in a safe, friendly, but productive way. One where we don't mince words and one where we deal directly with issues. And with that, I just want to say thank you to one of our partners, the Black Leadership and Crisis Coalition. They have worked with us on HIV/AIDS. They actually have a video which is available on the Lowery Institute Facebook page. I recommend you check it out. It's called All Boys Aren't Blue, and it gets into more of what we're going to talk about today. This idea of why should I care about HIV/AIDS in the Black community? If I'm a college student, if I'm in this community, why should I care? Hopefully, by the end of our conversation today, you will not only know why you should care, but you will care. And you will be committed to being an activist with us and going in our next steps to deal with this process. Allow me, before I bring up our program, to tell you how the program is going to go. I'm very excited. The next guest I'm going to call up is my co-host. He's a student at Clark Atlanta University in their master's program of social work. He and I are going to talk for a little bit about the issue, sort of set the stage, if I will, for what we're going to get into. Then we'll have the privilege of introducing our esteemed panelists who are experts in the field and know more about this issue. It can really illuminate the conversation we hope to have about this. So without further ado, I want to bring up my co-host. He's, as I said, a student at Clark Atlanta University and a master's student. His name is Devin Marks. Devin, how are you, sir?
I'm good. How are you this evening, Blake?
I am doing wonderful. In full transparency, we had a third co-host who was going to be with us today, but unfortunately she was struck ill and was not able to join us. Our prayers are with her. With Dominique now, but she was really prepared to talk with everybody. So in the spirit of Dominique, Devin, we're going to keep going and we're going to talk.
We're going to hold it down.
We are going to hold it down. So I just wanted to set the stage for a minute, Devin. Let's tell everybody what we're going to be talking about.
So basically, like you said earlier, we're talking about why should we care about HIV and AIDS, and in my opinion, STDs, any sexually transmitted diseases, do not discriminate against anybody.
Mhm.
It's available. It's there to harm anybody. And if you aren't responsible with your body, if you aren't responsible with your sexual health, you can contract not only HIV, but any other STD or STI out there. So I think it's important that we're alone having the conversation and just introducing it to people who don't have, maybe have some misconceptions, or, just they thought one thing and maybe it's another thing, or it's been presented as one thing, but then it's like, no, this can affect everybody. This isn't, just solely focus on one group of people, the way the media sometimes has portrayed it.
Yeah, and I think that's important, right? Because one of the things we want to do in this conversation is tackle these barriers, right? And deal with these complicated ideas, right? Involving stigma and barriers to care, right? And when I was doing my research, because Devin, you know me, I never come without looking up, an issue and doing my work. And one of the things I was struck by is still in 2018, Georgia was one of the highest states in terms of HIV rates in the country. And it's still ranks incredibly high. I tried to find data from last year, but I guess the COVID kept us from getting accurate stats from 2020, but we're still ranked too high. And the more I thought about it, I wanted to get your idea about this, Devin. I was thinking about, I kept having these words come to mind, like, okay, stigma, identity, and also kind of a relaxed attitude toward HIV/AIDS, right? Like, I know we're in the midst of a pandemic. So I know people get it, we don't want to throw the word pandemic around too much, but we've been in a pandemic for decades with HIV/AIDS. And it's something that we need to talk about more. I don't know what you think. Do you think part of the reason for that nonchalance, I'll say, in our generation is sort of, it was big once, but it's not going away, and now you can get cured. What do you think?
I think to this day, people still associate HIV/AIDS with the LGBT community as if it's an exclusive, virus solely affecting that group of people, and it's not. It affects everybody, and it can affect everybody. I believe it didn't come out in the 80s, but I remember in the 80s and like the still early 90s is when it was, at its highest, and it was affecting a lot of people. And at the time, it was affecting, majority of Black LGBT people. And at the time, it was kind of like it still was seen as, well, that's them. I'm sorry that you all gotta have to deal with that. And I believe it wasn't until other people started to contract it that it then became, okay, no, we got to deal with this. We got to talk about this. We got to do something about it. And unfortunately, even to this day, when I'm on certain, television, watching certain television channels, it doesn't really matter. Certain times, if I'm watching a particular channel that's LGBT oriented, that's when I see all of the HIV and AIDS commercials. I don't see the HIV and AIDS commercials on a regular, during ABC, during Modern Family, or during Family Guy, or during, a regular family-oriented show. I'm seeing it specifically when it's during an LGBTQ-driven network or television show that's on, or whatever, So I think to this day, people still exclusively look at it as an LGBTQ issue and not a human race issue, the way we look at the current pandemic.
I love that. And well, you know what? That's why we're here. We're here to have real talk about this. We're here to talk about this issue, to confront it, and to gain awareness. Because hopefully, as I said, by the end of this conversation, why should I care? You should care. And you should know why you care about it. And you should be as invested as we are in coming up with next steps to talk about this issue and dealing with this problem. Well,
absolutely.
I don't want to take the limelight anymore. I think we've talked enough, and I think I'm ready to get an expert in here. I'm ready to talk to somebody who's been working on this and really knows what they're talking about, so we can feed the minds of those listening to us. Can you do the honors of introducing our guest, sir?
Yes. So as of right now, we were going to introduce a wonderful person that is going to really give us some good insight and hold no words back. He's going to just do his best and tell it how it is. And that is David Malebranch. He has a doctorate in master's in public health, is a board certified internal medicine physician with clinical and research expertise in sexual health, men's health, student health, LGBTQ plus health, and HIV and STI prevention and treatment. He is also a public health official, activist, and health equity educator who lives in Atlanta, Georgia, and appears in the YouTube series Revolutionary Health as a part of the Counter Narrative Project and also the hashtag Ask the HIV Doc video series. Dr. Malebranch's writings and research have been published in the JAMA, the Annals of Internal Medicine, the American Journal of Public Health, and the Lancet. In 2015, he penned a memoir entitled Standing on His Shoulders about his relationship with his father, which is available on our Amazon.
Oh, all right. Dr. Malebranch, let's get you in this conversation, sir. How are you? Oh, I have to unmute you. I cannot let you not talk. How are you, Dr. Malebranch?
See, I was so excited to start talking that I forgot I did that move that everybody rolls their eyes at. Yeah, I'm just happy to be here, and y'all kind of set the stage pretty well. So I appreciate Blake, you, and Devin, you as well, for kind of bringing this to the forefront. And I also want to thank the Joseph and Evelyn Lowery Institute for actually hosting this event, and Black affiliated with AHF for having this. So it's really an honor to be here.
It's such an honor to have you, sir. And I'm trying to get over my giddiness. I don't want to throw too many questions at you too early, but I just wanted to ask you, sir, as an expert in the field, was the information that I gave correctly, or can you help us really set the stage? What is happening, particularly in Georgia, in Atlanta, with HIV/AIDS?
Well, I mean, we see the rates are still high, and I think you have to kind of look at a federal level or on a countrywide level with the United States, and we see probably about, I think the most recent data we have for the country is 38,000 new HIV infections, and that's from 2018. So that's even a bit behind, and obviously that's because of the COVID-19 pandemic. All the resources went to that. Usually we're about a year to two behind with the data as far as the years are concerned, but obviously some things have been delayed. Now, and 42% of that is representative by Black folks. So whether it's rural or urban, we seem to bear the disproportionate brunt of new HIV cases and diagnoses. If you funnel down into the state of Georgia, I know we're either in the top 5 or at least the top 10 that we've been consistently. It gets so consistent that at a certain point, you don't just keep going up and showing the pie charts and the bar graphs, because it's the same old shit every time. And so, I could just say it's really, really bad in the Southeast. It's really, really bad among Black communities, because as we only represent maybe 13 to 14% of the population, for us to represent 42% of the new cases, that's really an inequity. And if you look in the state of Georgia, the common offenders are the places where, it's most densely populated, and it is predominantly Black. So Fulton County, you look at DeKalb County, there's also Gwinnett County, Clayton County as well as included in that. But even when you expand out a little bit further, you see in some of the more rural areas, Columbus, Georgia, Valdosta, Savannah, Georgia, you see in some of these rural areas, you're going to see high rates per population. Now, remember, they say number of cases per 100,000 people. And so some of the rates that we're seeing in areas like Savannah, Valdosta, Columbus are actually pretty high, given that they're smaller communities. And so I think as we're looking at this both as a countrywide phenomenon as well as a state phenomenon, we have to think about it as not urban versus rural. We're kind of all in this together, and there are different dynamics at play as to why there's such an inequity when it comes to HIV rates and treatment and access to care in urban areas as with rural areas. But the end result is still the same. We're getting hit pretty hard.
We are. And I'm so glad, I think this is why it's so important to talk about this. And you hit on one of the next areas I wanted to go into, which was these barriers and access to care, right? Because the more I was researching and the more I was looking into this topic, we talk about, the rates are spiking in, as they say, in disadvantaged populations, as you listed, in areas of Georgia that may not have the highest median income, right? But what are some of the challenges that come into that, right? So if we were going to dive deep into that, okay, we know that HIV rates are high, say in Fulton County, but how does that exacerbate the problem and make it worse?
You mean why does it get that high, or what are the factors that are kind of at play there?
Both, yes.
Yeah, I mean, and before I answer your question, I just wanted to hold space in memory of Dean Maurice Washington. I know he had passed last week from Morehouse College, and I want to send my love to his family. I got a chance to work with Dean Washington on Morehouse College's campus not too long ago, 2-3 years ago, and he did a lot of work and was really an advocate for all the students. So I just want to send my love out and tell that brother to please rest in power. But regarding your question, I think, there's a lot of things with it. And I think the silver lining of looking at the COVID-19 pandemic, and like Devin was saying earlier, how it's affected all people, instead of folks with HIV can kind of be like, oh, those are those gay folk. Oh, those are those injection drug users. Oh, those are the Black and Latino kids. Like, that doesn't have anything to do with me. COVID-19 hit everybody. And so what happened is that it really uncovered a lot of the inequities that are built on structures and systems that go back through slavery, Jim Crow, and the continued scourge of white supremacy. And we're not just talking about law enforcement, redlining, employment, educational disparities and inequities that we see, but we're also talking within the medical system itself. If you ever listen to public health officials or medical officials, they act like the scourge of racism just happens in these other social contexts, and that we as the medical profession, we're not ever racist. We've got medical doctor, we've got MD behind my name. I'm a nurse practitioner, I'm a physician assistant, I'm a nurse. We can't possibly be racist. But in my estimation, doing this work for 20 years, I can tell you the only reason why it's not documented as heavily is because the medical and public health professions are afraid to put the mirror on ourselves and show how the same racism that drives cops and systems of law enforcement and the prison industrial complex to traumatize and disrupt Black families, they do the same thing in medical facilities as well. And whether that be, someone getting a cardiac catheterization who's having chest pain, and the provider looks at them and sizes them up because they're Black, doesn't know their own bias, or maybe does know their own bias. It's not always an implicit bias. And they decide just to go with some conservative booty therapy instead of the guidelines that are supposed to be given to everybody. That same thing happens when people come to sexual health clinics or primary care clinics looking for HIV testing. I've heard many times that people will say, if somebody's straight or they're a straight woman or a cisgendered man, someone will say, oh, or they're married, oh, you don't need an HIV test. Now, why would you tell somebody coming into your office who says, I would like an HIV test? Why would you tell them as a medical provider that they don't need it? Even if they don't tell you what kind of sex they're having, the fact that they're requesting it should give you a little bit of a clue that they may be doing something that they're worried about, or maybe they had a sexual encounter without condoms that they're worried about. But you see that all the time. HIV testing, you see it with pre-exposure prophylaxis, the pills that we're able to give to prevent people from contracting HIV, as well as post-exposure prophylaxis, which when, is a situation where if you have sex and it's without a condom, if you get to the doctor within 72 hours, you can get a full month of treatment that will prevent you from contracting HIV. We see all these things kind of play a role in this, and that's where the bias that infiltrates, that is the fabric of the United States society. White supremacy, anti-Blackness is the fact. People keep saying, this is not us.
Preach.
That's wrong. This is exactly us. This is exactly what the United States is. And we've seen that bear out for the past 4 years. We've definitely seen it bear out in the past 3 or 4 months. But that same thing happens. It's an umbrella, and it also coats into sexual health, HIV prevention, HIV treatment. And unfortunately, we get the short end of the stick as Black and brown people because of that racism, because of that bias.
Thank you. I'm so glad we were able to put a name on that. And because to me, that's part of the question here, right? It's one of the ugly ducklings in the room that we try not to talk about, right? Is the impact of racism, the impact of discrimination on this issue and how it is affecting us. And it's making healthcare and it's making awareness about HIV/AIDS even harder, when an issue that we understand is sensitive and private, but people don't want to talk about it. And people don't want to deal with this issue in part because they can't go to their doctor and have open and honest conversations. And I'm really glad.
Yeah, you're absolutely right. And also, if you see representation, like it's in not subtle, but not so subtle things like this. Like the United Nations of Women had some kind of, they have a Twitter handle, and they put something out about women and for Valentine's Day and loving each other. And they had this illustration with animated, and they were all couples. And it was like an interracial couple. It was two women together. It was another cisgendered heterosexual couple. And then they had a dark-skinned Black woman hugging herself. And that was what they put out for Valentine's Day. And everybody was like, what? Like, how are you doing that? But when you see those things always going in on the most healthy part of it, that's infiltrating into everything. So it's a part of the fabric of the United States. It's a part of the fabric of the globe. And we have to keep on fighting this and be vigilant in bringing it up, because it affects not only our employment, our educational opportunities, our ability to get insurance, make good money so we can get proper health care. But then even if we have all those things, once we get inside the medical profession and we get into clinics and hospitals, then we got to deal with the one-on-one racism and the systemic racism. And it's just kind of a confluence of all these systems that put us at a real disadvantage. So, you know, we've been fighting this stuff for a long time, and we're going to keep on fighting. That's all there is to it.
Absolutely. And Dr. Malebranch, before I have to transition in a moment to bring up our next panelist, but I wanted to ask you, from your experience and from looking at this issue, what would you say the role of community is in dealing with HIV/AIDS, right? There's certain taboo, there's certain things that people don't like to talk about directly, and especially in the Black community. We can go ahead and name it. We don't like to talk about the role of identity, or we struggle with dealing with our children in that regard, dealing with ourselves in that regard in a lot of ways. So in terms of this and HIV/AIDS and what Devin was talking about earlier, in terms of this stigma that exists with that label, well, it's a homosexual disease. It has nothing to do with me. If I can even get a test, I'm dealing with that. What would you say? How can we help the community deal with that, overcome that?
Yeah, I think we have to have more conversations, open conversations where we listen. I think we have to have some honest and open conversations about the duality of religion and denominational religions and doctrines from religion, and how they may be affirming to a lot of us on several levels. They can also be very destructive and insidious on other levels. And so we need to have those honest conversations. Then we have to talk about, when we use the phrase Black Lives Matter, that it means everybody. And it's not something where you just say, oh, Black Lives Matter, except for you, transgender girl, except for you, non-binary person, except for you, homosexual. Like, you just can't do that. If it's Black Lives Matter, all Black Lives Matter. And what's happened as a result of that is because, when you look at LGBT communities, they tend to represent very white. And there's also a certain amount of racism that's entrenched within white LGBTQ communities. And so when you see people, there will be Black brothers and sisters and non-binary folk who will run and deal with the racism of the LGBT white community over dealing with being stigmatized by their family, their churches, their communities. So when we talk about community, we have to be very clear and not use terms like inclusive, which means you're actually letting someone in. It means like, okay, we've got this secret society and we're going to include you. It's like saying to somebody who's not heterosexual, who's not cisgendered, say, oh, well, I'm going to tolerate you. Well, we tolerate other lifestyles. There's no such thing as a lifestyle. No such thing as a homosexual lifestyle. No such thing as a heterosexual lifestyle. You won't hear me saying stuff like, oh, some of my best friends are straight. I really like you guys, but I don't agree with that like opposite sex thing. Like I'm really not down with that. And so you see how silly it sounds when you flip it on its end. But I think when we look at our Black communities, one, recognize how diverse we are, whether we were born in the United States or we were born in Africa or the Caribbean or another country, or for first generation. And then also embrace that we have a diversity of religious beliefs, sexual orientations, gender identities, but we are all people of African descent. And I think if we can kind of start there and think on a more positive light, instead of letting the structure and the systems of white supremacy and anti-Blackness convince us to separate ourselves, then we'll be in a good position to fight this virus.
Dr. Malebranch, that was just love what you said. And it is honestly the perfect segue to bringing up our next panelist, who I wanted to invite into this conversation to sort of continue the conversation we're having about HIV and AIDS and its impact in our community, but to really get into this idea of community and dealing and how we can relate and how we can talk to each other. Devin, do you mind introducing our next guest? I know you've got her brilliant introduction up, and you did such a fabulous job with Dr. Malebranch.
Yes, let me pull it up.
Thank you, sir.
Okay. So, Dr. Sanders-McMurty is the Vice President for Equity and Inclusion and Chief Diversity Officer. Originally from, Pasadena, California, Sanders was inspired to become a full-time diversity educator after the deaths of Matthew Shepard and Sakia Gunn. Both individuals were targeted and killed because of their gender and sexual identities. A nationally recognized advocate for diversity and inclusion, Ms. McMurty has been quoted in publications including the Chronicle of Higher Education, Inside Higher Education, and Insight into Diversity magazine. Her research has been published to the Journal of Higher Education, and she has presented nationally at a wide range of conferences and institutions. She has held numerous leadership positions, including serving as the co-chair for trans inclusion with the National Association of Student Personnel Administrators, and was named a Diamond honoree with the American College Personnel Association. She previously worked at Georgia State University and ORC Macro, a public health research firm. Sanders holds a doctorate in educational policy studies, a graduate certificate in women's studies, as well as master's and bachelor's degree in sociology from Georgia State University. A high school dropout, she credits her non-traditional academic journey to her mentors at Pasadena City College, where she completed an associate's degree in social sciences.
Thank you, Devin. Dr. Sanders-McMurty, how are you, sir?
Hello. How are you? So good to be with you all. Thank you.
Doing wonderful. So glad you were able to join us. And thank you, Devin. I had to make some room on the screen because I know that the conversation is about to get very, very, it might expand a little bit. So I hope Devin can get mine, but that's why I had to do that. So glad you are here. And I wanted to kind of just to jump right into where Dr. Malebranch left off, talking about this idea of community and how we can deal with each other. And from your experience, Dr. Sanders-McMurty, and some of your expertise in dealing with these issues, what would you say? How would you say that the community can overcome this idea of stigma? How can we confront this, especially in terms of HIV/AIDS?
Yeah, first of all, everything he said, I was like snapping my fingers. There's so much here, right? I think one of the things that I wanted to say, I'm really grateful to Evelyn Lowery and the Lowery Institute for basically illuminating a problem that we really need to continue to address. And I think one that has such longstanding impact in our community. And in particular, I think what Dr. Malebranch, am I saying it correctly, said was so powerful about Black Lives Matter. I actually had that exactly in my notes. And I find it really interesting that many people don't realize that Black queer women started Black Lives Matter, that hashtag, right? And so when we call out the names of Alicia Garza and, Opal Tometi and Patrisse Cullors, recognizing that they have intersecting identities is really important. So if we're going to talk about how, their movement around Black Lives Matter was not just about centering just Black voices in terms of this being like a monolithic idea of like what a Black person is. We are all a multiplicity of identities in who we are. So, you're a father, you're a Black man, you were a student at one point, right? None of us should have to leave any parts of who we are at the door. We should be able to bring our full selves into understanding our humanity. And I think one of the things that we have learned with this epidemic, not just with COVID-19, but with the ongoing epidemic of systemic racism, and in particular with the HIV/AIDS epidemic, is that the stigmatization around particularly lesbian, gay, bisexual, transgender, queer plus people has to end. And it should end because we don't believe in a hierarchy of human value. So if we actually believe not just that all Black lives matter, but that as human beings, we should be able to live as our full and authentic selves, we should always recognize that we should be challenging homophobia, transphobia, xenophobia, anti-immigrant rhetoric, anti-Asian rhetoric, like these are sort of like perpetuating acts of violence. And I'm glad that I don't really like my whole bio read. So I'll just say this pretty summatively. One of the reasons why Sakia Gunn and Matthew Shepard's stories are so powerful is because really hate led to their assaults, right? And led to their murders. And if we continue to not operate from a place of radical love and radical empathy and radical acceptance, then we will, continue to have violence aimed at our communities. And so we have to speak up about these issues. And I'll just say one last thing about this, and I know you probably have other questions for us. George M. Johnson's book, All Boys Aren't Blue, is an incredible book because in part, in the film that I know was a part of what you're, going to show and feature on the website, I was able to watch, and Mara Kennedy, who I want to shout out, made sure we were able to watch it. There's this way that George M. Johnson talks about the radical acceptance of his family and the fact that they, saw him as a young boy who, as he described, was effeminate and also identified very early on, even if he didn't really know what his sexual identity was or sexual orientation was, he knew that in ways that were really toxic and harmful to him, that he was not being accepted by people outside of his family, but his family saved him. His community eventually embraced him, and he came to love himself and more fully, radically, transform ways that we think about how we speak up for people who are living with HIV and AIDS. And that's incredibly important. So I would just say that.
Absolutely. And I'm so glad you mentioned that, because y'all are doing a fantastic job of helping me lead to my next question. I feel like I'm actually getting this interview part right. So I'm grateful for that. And I wanted to put this question to both of you, because I also watched that video. And before we jumped on this live stream, I actually had a poll done with a couple of students at Clark Atlanta University, just trying to get the temperature of conversation around HIV/AIDS. And a couple of words came to me that I wanted to toss out here to see how you two what you thought about this. So when I was speaking with a student, this student was at Clark Atlanta University, asked to remain nameless, and I will of course respect that privacy, but they were talked about this idea that on campus or even around them, there's that idea of taboo, and this idea that it's not that HIV/AIDS isn't a major issue, but in the words of this student, Magic Johnson has it and he's fine. So, I mean, it's not as if to say this isn't an issue anymore, but that it's not something that for some students is prevalent or is like the top, is their number one worry. And to me, I get worried hearing that. That's being quite vulnerable. But I also feel like, okay, is that progress or is that a hindrance? Dr. Malebranch, what would you say to that student?
Yeah, I mean, I'm going to cop out and say it's a little bit of both, because because to be honest, that's the truth. I think, one of the topics that you're broaching right now is what a lot of people who have worked in the HIV field have talked about, and particularly now we're talking about more than ever, which is the phrase called HIV exceptionalism. And what I mean by that is that there was always kind of an exception with HIV when it first started, because it was taking out people so quickly. You needed specialized treatment, you needed specialized medication, you needed a specialized consent form to get an HIV test. Back in the day where you couldn't just get a finger stick, you had to have your blood drawn and then wait 2 weeks for the results to come back. Like, those are the days where it really had to be focused on just HIV. And I think what's happening right now is that there's a process of normalization of HIV. So a lot of people will say, and I just tweeted about this today, because you'll hear a lot of providers say, you could have a brother or sister or somebody come into a clinic and they've just been diagnosed with HIV. And the first phrase that you're going to hear out of the medical provider's mouth will be, well, HIV isn't the death sentence that it used to be. And while that's well intended, for a lot of people, it scares them. For a lot of people, they're not sure what that means. And then when you throw the word death in there, they're like, why are they mentioning death? Because I didn't know. Because a lot of folks weren't around in the days where people were dropping like flies. And so what we're trying to do is get something where it's what we call HIV neutral, right? So an HIV neutral approach would involve not focusing, like not having a clinic and saying, oh, if we're doing prevention, it's over here, or sexual health and STIs are over here. And then the people living with HIV, y'all are over here. bring everybody together. So it's a fine line, and it's like a tightrope balance that you have to do here, because you have to normalize it to the point where you say, well, yes, people can live fruitful and productive lives, and just as long as everyone else, if they take their medications. And yes, in that respect, it is somewhat similar to diabetes, high blood pressure, and other chronic manageable conditions that people will live their entire lives as long as they take their meds. However, where it drifts apart is that you don't have the stigma and the judgment and the consternation when somebody says, I am living with HIV, as you would have when someone says, oh, I have high blood pressure. They don't say, well, oh, wow, you're just eating too much salt, and then really dog them and say, you must be like just fat and just, you're not doing anything, and all this negativity. But as soon as someone says they're living with HIV, the immediate conclusion is, oh, you must have slept around, or, oh, you're doing this. And there's all this other stigma that's related to that. So I think what we're doing right now, and this is 40 years into it, that we're talking about HIV and the epidemic, we're at a crossroads where we really have to move forward in our language and do the tightrope, like I said, of pushing forward and being positive that, yes, this is a manageable condition, but two, understanding that even though we have science, we have single tablet regimens, we now have injectable medications that just got approved that people can take every month, and they can just get 12 shots a year, and that will treat your HIV if you're living with HIV. We have these scientific advances, but unfortunately, the social progression in the country seems to be going backwards. And so that unfortunately puts a monkey wrench in a lot of the science. So we have to make HIV, keep it exceptional in the way we look at stigma and handle stigma. And remember, it's different from other chronic conditions, but then also normalize it to the fact where I dream of having clinics in the future where everybody can just come in and there's not going to be one person that says, oh, they must have HIV, or, oh, they must be here for STI testing, or, oh, they're here for this. People are there just to get their health taken care of, their health and wellness. That would be a wonderful thing. And the providers are going to be experienced in doing a litany of tests, a litany of conditions, and can do that. So I'm hopeful that that day will be coming, that we'll able to bring things together, but still recognize HIV and the stigma that socially still comes with it.
See, that to me, yeah, that because dealing with that stigma, and Dr. Sanders, I'm going to send this question your way, is because I also saw a little bit of that video. For those who have not seen that movie, I strongly encourage you to watch it. It's such an amazing video, and it's an amazing book. But one of the other questions that I've gotten from a student, and I'm of course going to open this up so we get more questions from our Facebook audience, but this question really struck with me too, Dr. Sanders, and I wanted to put it to you. It was a question about, okay, when it comes to HIV/AIDS, and it comes with, we've talked about the stigma, right, of living with HIV/AIDS, but there's also the stigma that comes from being tested and being around your peers, particularly on a collegiate campus, where these labels and these identities can get put on you in such a way that they become impossible to shake. And then you feel isolated or detracted from your friends or from your peers. In the book, they even mentioned there was they talked about pledging and the fraternity, being a part of the brotherhood. Yeah. And so I wanted to ask you, from your knowledge, both as an expert in this field and also just from being an educator on a college campus and dealing with students and talking directly with them, what can college students do to try to create a more safe, open environment where they can deal with this issue and openly talk about it?
Yeah, I love this question. And I think I want to just say one other thing about something Dr. Malebranch said, because I see it as like freedom dreaming. There's this, work by Robin D.G. Kelley that talks about, what if we really imagined a world where there were no hierarchies, where we all were free, and we all had the ability to talk openly about the things that we were challenged by. And I feel that so strongly with college students, right? That I happen to do work, and I always give a content warning because there's so many people who are survivors of sexual trauma in spaces like this. The statistics show us that, and it bears out in terms of, the data. But I think about this a lot when I think about sexual assault and even consent conversations, right? We don't talk openly about the fact that not only are people having sex, but people don't always know how to ask for consent or ask for a person to engage with their bodies in certain ways. And in part, some people have either suffered trauma in the past, right, related to maybe their inability to give consent, or having people have harmed or hurt or assaulted them in some way. And in some cases, I meet so many students who are really ashamed to even say, I experienced sexual trauma, I experienced sexual violence, and I don't really actually know how to have a healthy conversation about sexual intimacy. And so I think that that's incredibly important, particularly for college students, to find safe spaces. And we need to be creating safer spaces to have these dialogues with one another. So I link like sexual violence to that, because I think it's also true when we talk about, understanding someone's, STD exposure, like what has been their history with who they've been partnered with, and whether those individuals have been tested. And that's really critical to thinking about how to make sure that we're lowering the incidence, right, of the number of people who are then impacted if we're not having open, honest conversations around sex on campuses, whether it's sexual violence or, being a survivor of sexual violence, or talking openly about the fact that, I was intimate with someone who wasn't honest with me, or I haven't always used protection, and, or I want you to use protection. I've actually talked with so many students who are too ashamed to tell their partner, I'm not going to have sex with you if you don't use protection. I mean, that is a huge problem. I'm sure, Dr. Malebranch could speak to this even more directly. So I think, particularly thinking about the intentional programming, which is why what you all are doing at the Lowery Institute around this topic, engaging students. I mean, I can't be laudatory enough. I think it's critical. I think naming the fact that we have these stigmas and where they come from, what their origins are, and how we can work to eradicate them, being very clear that we want to eradicate them, that we don't want anyone to feel that they need to hide any parts of themselves to be engaged in a conversation. And then, ultimately, one of the things we need to do is think more critically about how leaders at our higher education institutions are more vocal about and are more visible on these topics, right? And so it's just really important to think about all those things, because what tends to happen is people feel as though they're going to be castigated and ostracized, and that they'll have no community. So, imagine if we're going to freedom dream together. I'll freedom dream with you, Blake, and Dr. Malebranch. Imagine if we have testing, regularly available on campuses. If we have dialogues that are, consistent around not just consent, but sexual intimacy, what that needs to look like. Of course, it can include conversations around celibacy if that's a person's choosing, but it can also include conversations around, having sex safely with whoever you want to have sex safely with, right? And so it just needs to be an ongoing dialogue. But I think the piece of that is recognizing that it's a public health crisis. If we don't actually, engage and name these difficult topics, we will never eradicate HIV/AIDS in our community. And I know everyone on this call has had someone that they've loved been either affected by this. Either they've lost a family member, they've lost someone else that they knew, or they know someone living with HIV/AIDS. And we don't actually always feel comfortable saying, or creating safe space for people to say, I'm living with HIV/AIDS, which again is why I'll go back to the book for a moment. I think people like George M. Johnson, I think about Jonathan Van Ness, who's on Queer Eye for the Straight Guy. Like, there are people who are out here saying, I'm not going to live with shame anymore. And so, but they're doing that and possibly facing consequences. So if more of us get together and say, no, not on our watch. You should not be ashamed. You should be able to be yourself. You should be able to talk openly about these issues. That's really critical, and that's going to make all the difference.
Thank you,
Blake. If I could just add right quick. I know you have to move forward. I just wanted to add to what Dr. Sanders-McMurty said. That's just so important, because I do think we don't start talking about stigma until we talk about HIV, and that's typically the public health approach, that you wait till a disease comes or a crisis happens, and then you work backwards. The stigma doesn't start with HIV. It starts with sexuality and sex in general. And the United States is the most conservative / hypocritical area on the globe when it comes to sexuality and sexual expression, where you see in the Southeast, particularly where the heart of the HIV epidemic is, where do you see the most religious constitution or the most religious discrimination is going to be in the Southeast. Where do you see the most clandestine use of porn? on the internet in the Southeast. So it's like we talk out of the sides of our necks about sexuality. And so if we're going to have a conversation about sexual violence, about HIV, about STIs, we have to start talking about sex first and start talking about sex not in negative or punitive or you better watch out, you're going to get a disease or get somebody pregnant kind of warning ways, but speak about it in a positive light and be sex positive. What do we have sex for? We have sex because it feels good, because it's pleasurable. That's why we have sex. If we go back to that, start having those conversations and allow people the freedom of expression to say their diversity and what they enjoy about sex, how they experience sex, how they love sex, let people do that. And then we can have the conversations about the rest. We're not even at step one where we can have healthy conversations about sex. So how the hell do you expect us to get to the point to talk about sexual violence, intimate partner violence, HIV and STIs when we can't even talk about sex? So that's where it comes out. So that point that she just made is so tremendously important.
I mean, this is why we're having real talk. I mean, I love it, and I really want to get deep. I'm trying not to be selfish because I have so many questions myself, but I'm going to bring Devin up in a minute because Devin has been quietly collecting questions from many of our collegiate brothers who have tons of questions. I'm not going to be able to get to them all because I am going to respect the time commitments that we have. And if anybody on Facebook has a question they want to submit to the chat, please do. And I'll ask it to our guests for the next 5-10 minutes, as long as they'll allow me to stay. But Devin, I know you had a question you wanted to ask.
Yes, literally what Dr. Malebranch just said, literally kind of was going to ease into that question. Just as far as we're not even at the step where we're comfortable having those type of conversations. And one of the questions that I have is, how present are cultural biases and homophobic ideologies surrounding the topic of HIV within the Black family and household? Because I know just in general, like I think, like you said it earlier, how just within our community, the Black community, we don't want to talk about nothing. We don't want to talk about trauma. We don't want to talk about sex. We don't want to talk about nothing. If it ain't, if it ain't Christ-like, if it ain't that, we don't want to talk about it. So for that question, how prevalent do you think that is within the Black household?
I'm going to say this real quick, and I'm going to let Dr. Sanders-McMurty expound because I know she has a lot to say about this. But I will say this. In my 20 years of experience, we have to acknowledge that, yes, there is, I don't use the term homophobia. I call it sexual prejudice. I think that for me, that encapsulates what people are doing. They use their sexual prejudice against other people. Yes, it is present in the Black community. Do I think that it's more prevalent in the Black community than other communities? There's actually a lot of research that refutes that on several different levels. And so we have to acknowledge the media spin that tends only to talk about sexual prejudice when it comes to the Black community, the same way they only talk about vaccine hesitancy and focus on the Black community. When a lot of people are hesitant about taking the COVID-19 vaccine, and a lot of people are sexually prejudiced against diverse queer representations. So what I will say to you is that, yes, it is an issue, but I do think similar to what, and George Johnson's book is absolutely phenomenal. And he's just a brilliant and bright spirit in this world. There are more stories like George Johnson's stories. I could tell you more stories about patients of mine who came in. I had one patient that came in, I remember several years ago, and he brought both of his parents who were pastors. He was not only gay, but he was living with HIV, and they were supportive of him. The reason why you don't see these stories is that the media likes a negative narrative. But there are those affirming stories out there. We just have to normalize telling them, telling our own narratives, telling our own story, and telling both the good and the bad. That's all I'll say about that.
Yeah, I love that you said that. First of all, that, that there are queer affirming families in the Black community. I do think, though, Devin, your question is a really important one because, some years ago, a friend of mine and we did a presentation called Many Rivers to Cross, like challenging basically homophobia, sexual prejudice. I like that as a new way of thinking about the concept in the Black community. And what we were really trying to speak to at that time, you all may remember this, there was a specific, on a historically Black college campus, there was a specific dress code policy that was implemented really in an effort to restrict and police expression, in terms of clothing. And so there are these realities that exist where there's sort of like this pernicious way that, in particular LGBTQ plus people, are sort of either regimented around dress or expression or identity. And so sort of like the don't ask, don't tell. So I agree with Dr. Malebranch that it happens in like mainstream society, but in many ways, what's happening with us is like a microcosm of what the mainstream society is experiencing. So it's important to recognize that. But I'd love to take it from like even thinking about like how we talked about sex positivity. What does it look like to have a queer affirming, right, LGBTQ plus affirming world that we live in, where, I'm going to use a phrase that some people might be familiar with, but as a diversity educator, I always want to break it down, what we call cis heteronormativity. This idea, cis, CIS, right, meaning that so if I'm a cisgender person, how I was assigned at birth, my gender is how I also identify. So I identify as a woman, and I was assigned female at birth. So when we think about like cis heteronormativities, there's this idea that when you're interacting with a young child, you might start to gender them or tell them certain ways they can dress or behave, right? Like we know it as like gender kind of policing, right? So girls are told this and boys are told this. And that is harmful, right? In so many ways. We've talked about how that manifests in terms of how, women can be paid equally or not. There's a Black Women's Equal Pay Day because of gender bias and gender stereotyping. So we're all harmed by what we call the gender binary, this idea that certain people can only identify as men and certain people can only identify as women, and there's no in between, when actually life has always been fluid. We've always had people who were fluid around their sexual identity, around their gender identity. There was just not a safe place to always be visible. So if we really want to disrupt, right, these stereotypes, these norms, and we really want to eradicate these sorts of ways that diseases can be furthered, whether, just inequity in our community, we have to address those stigmas. And so I like to see it as like, I'm not interested in keeping the patriarchy alive, the cis heteropatriarchy, the cis heteronormativity alive. I'm interested in eradicating all of that, disrupting all of that, and affirming, children and young people and myself and all the communities I belong to, and all the ways that can be affirming so that I can live a high quality of life. And that's really what we're talking about when we talk about challenging the HIV/AIDS epidemic, is that we want people to have a high quality of life. We want racism to end. We want all of these other isms to end. And the only way to do that is to speak life to them, speak to them, and address them, and finally, challenge them. And the only, one thing that I always think about with racism is, so we're now seeing, since the murders of George Floyd, Breonna Taylor, Tony McDade, Rhea Milton, Ahmaud Arbery, Rashard Brooks, I can go on and on. We're seeing this huge proliferation of anti-racism, rhetoric out here, right? Like I remember opening my TV and seeing Netflix said Black Lives Matter. And I was like, wait, just 5 years ago, right? Colin Kaepernick and other folks, lost the right to even just have their jobs because they, believed in Black Lives Matter. But now suddenly everyone wants to hire people like me to come in and help them solve racism. Really, white people have to solve racism, right? It's not Black people's job to solve racism. And if we really want to address prejudice in the Black community, particularly around HIV/AIDS, it is our issue to address, and we can do it, but we have to do it from a place of radical love, empathy, and support for one another. It's that simple.
I mean, yes. And I'm so glad. I was going to jump in and ask another question, but I'm so glad I kept my mouth shut, because I could not speak higher to what you just said. And I know time is getting away. I have another question from the AUC that I have to bring to the table with both of you quickly before we go, because I think it's very important and relevant. What would you recommend to either of you, to someone battling with the news of having HIV/AIDS or another incurable disease that is trying to look forward to their future, trying to build a family?
I've had to, I'm not proud to say this, I've had to do that a number of times over my career, is have a counseling session. And, one of the things is that everybody reacts differently to a new HIV diagnosis, right? I've seen folks break down in tears. And from the moment I tell them, hey, the test came back reactive or the test came back positive, they don't hear another word that I say for that entire session. And they will even tell me afterwards, they'll be like, Doc, You know, after you said that, no disrespect, but I couldn't hear nothing because I was just thinking about the next steps. Who do I need to tell? What do I need to do? Is my life over? And so I think as a provider and also as a friend who's counseled people who have been diagnosed with HIV, it's just to let them know that it's not, you can still do everything that you were supposed to do beforehand. And it's having those conversations, but also recognizing the trauma and the grief that comes along with this new diagnosis, because it is a loss. You're losing what your previous life was. It doesn't matter whether you can take one pill once a day and live as long as people who are not living with HIV. Your life has fundamentally changed. How you navigate your dating and sexual world is going to be different from this. How you navigate interacting with your family and your colleagues and your classmates is going to be different from here on in. So you have to actually be present for that, and you have to actually know that things are going to be okay while acknowledging that it's a difference. And so I just, the approach that I take is I usually go by the energy of the person who's sitting across from me. Some people need that kind of empathic counseling. Some people are like, hey, doc, what do I need to do? Give me them pills. I got to keep it moving. And they'll do it that way. But you always want to be responsive to them and let them know. You don't want to be too smothering because some people will react to that. You don't want to be too aloof, but you have to really gauge the room and say, okay, what does this individual need who's sitting in front of me? And what can I best do to kind of help them along and reassure them and affirm them that it's going to be okay? Because the reality is it is going to be okay. And they are going to live and they are going to be able to do all the wonderful things that they want to do, but they are going to have to adjust and change. And that particularly for young folks, anyone who's between, the ages of 18 and 24, it seems like, okay, my whole life is over now. What am I going to do? But being able to tell people like, look, it's not over. This is what you'll be able to do and move forward from there. But there's a lot of hope in this. And I am one of those people that believes there's going to be a cure. I'm seeing so many scientific advances and people don't know this, but a lot of people are skeptical about the COVID-19 vaccine, some of the COVID-19 vaccines and the mRNA technology. What people don't know was that scientists didn't come up with that technology just in the past year. And no, Donald Trump did not come up with that technology either, although I'm sure he would like to claim to. Scientists have been working on that for about 20 to 30 years with other viruses, including HIV. And they just had to shunt their resources to focus on COVID-19 because the pandemic was so urgent and immediate need had to be put there. But now what they know that these vaccines can be put out like this, and they could do clinical trials quickly, I guarantee you that whole knowledge base is going to be funneled back into fighting other viruses and other pandemics, including HIV.
Thank you, Dr. Malebranch, and thank you, Dr. Sanders. I wish I could keep you. I want to steal you for more. I want to go for another 3 hours and just really keep going. But
have us back.
We will. We will definitely have you back, sir, and definitely have you back, Dr. Kijua. Thank you so much for being here and for being a part of this Real Talk conversation. It means a lot to us. It means a lot to our audience, to our students, and I want to thank those students who submitted questions to me, those who submitted them to Devin, who did this anonymously. We hope I didn't get to all of your questions. I'm sorry. We will have to, I guess that means to do it again. So we'll have to do it again sometime. But thank you both to our panelists, Dr. Kijua, our board member, who's always been here with us at the Lowery Institute, and Dr. Malebranch, just an expert on this topic. We thank you both. We thank you so much for your time.
Thank you.
Thank you. Have a good night.
All right, Devin. Woo. See, that's why I like Real Talk, right?
Yes.
Because it gives us the opportunity, to touch on these things that, sometimes we're afraid of, sometimes that, one of the ways I felt really excited about this was, getting those questions from students where some of them told me they didn't want their name, they were afraid to come on, but just, I hope that they were able to get an answer that they were looking for. And I hope that, we were able to bring something to them. So before we go, Devin, me, I have to always talk about next steps, right? And where we're taking this. So if you enjoyed this conversation, this is the first of the Real Talk, I guess we'll just call it the Real Talk platform, where we are going to be talking about real issues. It's going to be change agents, scholar activists, are students using their voices to confront these issues. So if you enjoyed what you heard today, if you want to hear some other topics and other conversations, please join us again. Please come back. Here at the Lowery Institute, we're not done dealing with this issue. We are actually working over the next year. Devin right now is one of our students conducting a research project into education, looking at the impact of COVID-19 on virtual learning and middle school students. Am I saying that right, Devin?
Yes.
So next year, we're actually going to be doing a research project into HIV/AIDS and into the ideas of stigma and how we can lower that, confront that issue, confront that issue on campus. So this is something where if you're a student and you hear this talk and you're like, man, I really want to be involved in this. We're going to be doing this more over the year. We're going to continue to look into this area. Devin, I'm so excited to have you here, the future host of Real Talk. Is there anything to say as we sign off?
No, I just want to thank you for having me. I'm excited for what we have to come. I'm really excited. I enjoy these type of panel discussion, open discussions. So thank you for having me.
Absolutely. We will be back. Thank you to everybody. We will see you next time on our next Real Talk. Take care. Have a great evening.